Okay, welcome to RAAONLINE. I am Dr. Sudakshina, a professor of anatomy. I am going to talk today about a certain objective structured practical examination series in anatomy, which will be based on USMLE pattern questions, station questions, what you will be facing in the exams, some of the international exams. Okay, coming to the first slide, I'm going to deal with OSPE, especially in the limbs in this session. So the first slide is actually showing a person. It will be pictures of patients which are taken with hidden identity. And you can see over here that a patient is being shown from the posterior aspect and the back is being shown. And he has actually lifted the hands up as if he is pushing the wall in the front. And when we are seeing this kind of situation, in this kind of a condition, it can be well seen that on the right side, if you are observing it, you can see that on the right side, the scapula, the medial border of the scapula is very, very prominent, and he is unable to do this action properly, whereas the other side, the hand is getting abducted very easily, whereas here the hand has a limited abduction also, and there is a prominence of this medial border of the scapula. Now coming to this kind of a case scenario may be given in your OSPE station, and we will be asking these questions which are under these case, and it has to be answered within a particular time frame and submitted. So you have, first question is identify the clinical condition which has been shown over here. Name the nerve injured in this condition. Then we are coming to the relevant anatomy of this particular case. So this is a spot identifier short case, and you have to also name the nerve. So relevant anatomy. Mention the muscle which is also paralyzed over here. For that, this kind of a picture it is giving. The winging of the medial border of the scapula is definitely the clinical condition over here. List the actions lost in this patient. So let's come to the anatomy part of this particular picture which you have been shown in the station, and now we are coming to the anatomy. So now you can see over here that I am going to introduce you to one of the muscles which has got paralyzed and especially affected in case of medial angle of the scapula being winged, and responsible for that, and that is the serratus anterior muscle. Now serratus anterior is like a fan shaped muscle. You can see it is taking origin from so many ribs. It is actually the first 8 ribs or up to first 9 ribs. It has digitated origin. So it digitates, it's like digits. So digitations, it is taking origin from the first 8 to 9 ribs, and the lateral wall of the thorax, it starts, you can see over here, this is the scapula over here, and this is the rib cage over here, and it is one side is being shown, and all these digitations from the first 8 ribs or 9 ribs, they all join together and get inserted to the medial border, because this is the lateral border. It doesn't insert to the lateral border, but it goes and inserts to the medial border of the scapula. So superlateral surfaces of the first to 8 or 9 ribs at the lateral wall of thorax and inserts along the superior angle, medial border and inferior angle of the scapula. Basically, it is more on the medial border. Definitely the angles of the scapula will also get some digitations of this muscle. So this is a muscle which is taking origin from here, from the chest wall, the lateral aspect of the chest wall, and getting insertion to the medial border, superior angle and inferior angle of the scapula. So along the medial border of the scapula. Now let's see what is the nerve which can get involved. So this you can see over here, this is the rib cage. This is the brachial plexus which is originated, and below the clavicle it passes from the posterior triangle of the neck. The brachial plexus enters into the axilla, and already you know the brachial plexus have roots, has trunks, has divisions, and then you have cords and you have the branches. And there are 3 cords of the brachial plexus. All these things we have already taught you in the brachial plexus anatomy class, as it is an essay. But coming to the particular nerve involved in this case is the long thoracic nerve. Now, long thoracic nerve is taking origin from the roots of C5, C6 and C7. Brachial plexus is formed from the roots of C5 to T1. Sometimes it can be prefixed, so it can start from C4 and then it is also many times it is postfixed also, so it can extend up to T2 roots. They are anterior primary rami of the spinal nerves of C5 to T1 is mainly for the brachial plexus, which is contributing to form a nerve plexus, and this particular long thoracic nerve is taking origin from the roots of C5, C6 and C7. Okay, and this is the main innervation. This is the long thoracic nerve of Bell. It is also called, and you can see it just directly comes down along the lateral aspect of the thoracic wall and over the serratus anterior muscle. You can see the serratus anterior muscle is taking origin from the first 8 to 9 ribs, and it is going to the inner aspect of the scapula, medial border, superior angle and inferior angle of the scapula, more to the medial border of the scapula. So the long thoracic nerve will extend as far as the 8th or 9th rib. So it is just coming down. That's why the name was given as long thoracic nerve, because the course itself is so long. When we do the dissection of the medial wall of the axilla, you will be seeing a nerve which just comes down, straight down along the lateral aspect of the thoracic wall over the serratus anterior muscle, and it is one of the sole innervation of the serratus anterior muscle. It is long, it is relatively superficial in the course also, it can get injured, so it is very commonly associated with injury also because it is very superficial, it is lying above the serratus anterior muscle. The most common cause of long thoracic nerve injury is carrying a heavy object on the shoulder. So on the shoulder, if a heavy object, so this can actually cause a pull, and this can actually, very commonly this kind of injury is seen in laborers who are carrying lot of heavy weight on the shoulder, coolies and porters and all that. And the most common is, that's why heavy weight on the shoulder. Other causes, it can happen post-infection to the chest wall if you have done a radical surgery on the chest wall, injections, post-operative, that's what the surgery is. Postpartum also, this kind of injury is also common, and so these are some of the causes where the long thoracic nerve can get affected. You can also see the typical clinical presentation will be, in this case, a vague pain in the neck and the shoulder, radiating pain will be there. Inability, so what are the things which are not able to fully elevate the arm? So the overhead abduction. So in the case itself, you have seen in the picture itself that the abduction is more in this side. He is able to raise the arm above the head, whereas in this hand the arm is not getting raised beyond a level. So the overhead abduction of the arm is not possible.